I'll describe more about what OMS actually is. So there's a number of different names that it goes by depending on where you're living and where you're reading about it. Dancing eye syndrome, or DES for short, this is a term that they use in Europe more. Opsoclonus Myoclonus ataxia syndrome, you'll see if you're reading research or like in the literature, they throw in the ataxia. Dancing eyes and dancing feet, that's something they seem to use more in the media because it's kind of fun and it describes how their symptoms look. And then Kingsborn syndrome, that is a term they still use more in Latin America, and it was actually Dr. Kingsborn, I believe, that first described OMS. So what it is it's an autoimmune neurological disease where there's antibodies that attack the cerebellum mostly. And as the cerebellum has this autoimmune attack, they start to get the characteristic symptoms of the Opsoclonus Myoclonus and ataxia. But these are the most well-known symptoms, and they're really extreme and unusual looking. But there's actually a number of other symptoms that you'll see: dizziness, nausea, blurred vision, behavioral problems. So those are also part of the condition, and people struggle with treating those ones more than the others. So these are some videos of what Opsoclonus looks like. So, can you see it? I can make it bigger. Can you guys see that? Not yet.
We're gonna switch out here.
Is it still hard to see?
See it?
So yeah, you can see that his eyes are just bouncing around. It's basically a multi-directional nystagmus. And what is important to note about the Opsoclonus, from what I've heard from parents describe, and sometimes you'll read about it in research, the Opsoclonus can be constant, like there all the time. This is probably more severe, but there's some kids that have a really mild case of the Opsoclonus, and it will only be present occasionally, like when they're getting tired at the end of the day, or if they're focusing on a target far away versus up close. So there's different triggers for different kids. They're variable in how the eye movements look. So that's kind of important to know, just because if you see a kid come in with ataxia, then you might miss the Opsoclonus if you're not looking at one that sees it mostly when they're looking up close. So I'll show you the other video. So this is one of the girls that I met her mom in the support group we have, and she gets the Opsoclonus when she's nursing. This is a video of her nursing. You can see that one better, I think. So you can see that it's just a really fast, kind of bouncing around movement. Oh, and another thing it's hard to actually find videos of Opsoclonus. Parents will try to record the kids' eye movements, but they're so fast that when they're recording it with an iPhone, you'll like record it and then you'll replay it, and you won't even see it on the recording. So this is a boy. This shows more of the ataxia and the myoclonus. There we go. So this boy, he was 13 months old in this video. This was 4 weeks after the onset. And this is really common with the kids. They will go from, he was a normal, healthy, happy boy like 4 weeks earlier. One day he was running and jumping and dancing and singing, and then he went to this not being able to even hardly crawl. And they'll actually refuse to walk or crawl, and the parents will they say they can't even sit up on their own. And so the mom in this video is trying to get him to crawl over towards her. So you can see that he's just really shaky and he's kind of slipping as he's trying to crawl. hopefully you guys can see the myoclonus, the jerkiness there. So OMS is really rare. Part of why it's hard to diagnose is people don't see it very often. It's about 1 in 10 million in kids. So then, in my case, in adult onset, it's even more rare. I think I know of 4 other adults, and I've only met 1 other adult that's had it. So it's very rare. The causes can be paraneoplastic or post-infectious. The paraneoplastic is normally caused by a really small tumor. So the body starts to try to fight this tumor off, and they have a cross-reaction, and those antibodies start attacking the cerebellum. So the kid's part of the diagnosis is like looking for a neuroblastoma. The other case here, post-infectious, that is the kid will have like the flu or a stomach bug or something, you know, and a week or 2 later they'll end up with the severe OMS symptoms. But a lot of doctors and researchers think that almost all of the cases are actually paraneoplastic, and that even in the cases where they never find the tumor, they think the body had already fought off the tumor and it was gone, and they're left with just this autoimmune reaction going on. So these are some surveys we actually did. Because it's really rare, there's not very much data in the literature to find like statistics on how common it is. So this data actually represents about 150 to 200 kids throughout the world, and we got together in our support group. We have it online on Facebook, and the coordinators surveyed everyone in the group and tried to get more data. So that's kind of how we get our information, because it's so rare and there's very little funding, which is why we're doing the teddy bear drive. So this one you can just see that it's most common in like a year to 1.5-year-olds. So one of the most common issues is being misdiagnosed, and I surveyed the people in my support group and asked them what the doctors in the ER told them, or their primary care doctor, whoever they went to first, what were they originally given as a diagnosis. And the most common ones are this acute cerebellar ataxia, cerebellitis, and post-infectious ataxia. They're all kind of similar. Basically, it's just where the child ends up with ataxia as a result of a virus infection, which is more what these two are. Acute cerebellar ataxia can be caused by a variety of things. It's kind of a general diagnosis, and then the treatment will be based on what is actually the cause. So a lot of times these kids are in the ER, they're said, oh, they just have a viral infection, they're still getting over, go home, and they should get better, but the kids don't actually get better. They tend to get worse. The other thing that's really common is seizure disorder, and this is because the myoclonus can actually sometimes look like a seizure. There is a term that Dr. Pranzatelli uses called poly-mini myoclonus, and this is basically, in me, people will think that I'm like shivering, like I'll just be like really shaky, and it will die out after like 30 minutes. So I'll go through like an episode where I'm just like, it's basically like full body shivering, but it's like you're not cold. So it can kind of look similar to a seizure. A lot of times the kids will have testing to rule out seizures, and there are some kids that have both seizure and OMS. Some of the parents say that the opsoclonus starts later after the ataxia and the myoclonus, so that's also important to note. And Dr. Mitchell, she is a specialist in California that, there's 3 main specialists. She's one of them that does some of the research, and she wrote an article on DDXing cerebellar ataxia from OMS, and she actually suggests that even if you don't see opsoclonus, you have to rule out that it is OMS, because if you don't diagnose and treat it right away, you can actually end up with long-term developmental delays and other side effects. So this just is another survey from our group that shows how long it takes to get a diagnosis. Normally it's a couple months. And this one is actually from 2010 to 13, so this is more recently with more awareness and more research. It used to be 6 months, a year. It used to be a lot longer before there was more known about it. This is just a summary from that article I was telling you Dr. Mitchell wrote, and I just find it really interesting how she talks about how you, even if you don't see opsoclonus, you still should consider the diagnosis just in case. So I actually have this article in a PDF if anyone wants it. It's a pretty short, easy read, so I can get that out. And once again, like I said, I think it's fascinating. You can have OMS without Opsoclonus. This I thought you guys would find interesting. It isn't always, even though it's an autoimmune neurological disease, it's actually often the pediatricians or the primary care doctors that really are the advocates for these patients. For me, it was actually a chiropractic neurologist who has had like extensive training in neurology, and he had seen a video of Opsoclonus, and within 2 seconds of seeing me, he was like, "You have Opsoclonus." So it's just important, like, to get the diagnosis and then refer to the neurologist or the immunologist or whoever is going to treat it. So how do you diagnose it? So you do imaging to rule out the tumor and see if that's there. And even if you don't find a tumor, you can still have OMS. They do CT, MRI, and this MBG scan. It's a nuclear medicine scan, so they inject the like radioactive labeler and then scan you to see if it labels the tumor and if you can find it. The lumbar puncture, this is kind of interesting. I'm not super clear on it, but from what I understand and what I've talked to other patients about, Dr. Pranzatelli in Illinois, he developed a technique called, or I don't think he developed a technique, but he uses a more sensitive way of analyzing the CSF. It's called flow cytometry. And so some of these kids will have spinal taps done at certain hospitals and they won't see that the B cells and the T cells are elevated. But then when they go and see Dr. Pranzatelli in Illinois and he does it, he finds that the B cells and the T cells are actually elevated in a lot of these cases, but not always. So it's kind of, these are general things that you'll see in OMS, but it's basically diagnosed by what the patient looks like and ruling out other causes, of course. The labs, they always say and suggest to do the perineoplastic markers, but I've actually not heard very many parents say that their kid had positive antibodies. I know of 2 kids that had this one, and then myself and one other adult has GAD antibodies. This is glutamic acid decarboxylase. It converts glutamate to GABA. GABA is really highly used in the cerebellum to inhibit movement. So if you don't convert to GABA, then you're not going to actually be able to inhibit that movement. So then you get the Opsoclonus and the myoclonus and the ataxia. This is kind of interesting, just a survey about what scan identified the tumor. It's about like 50-50, like MRI and CT. They always suggest, like in the literature, they say like do an MBG scan, but it's not very common that it shows up on those. The other interesting thing is that these tumors are normally really, really small. So the parents will say that they are found on repeat scans because you're supposed to get a repeat scan every like 6 months to a year for however many years. They sometimes 5, sometimes a couple years. And so then it will be found a couple years later, say on an MRI. They'll go back and look at the original scan, and that's when they actually see it, and it'll just be like super small. Sometimes it will be up under the diaphragm, so it's like you can't even hardly see it. But they're there. And normally the tumors aren't the major issue. They do surgery and they do chemo, they get rid of the tumor. That's not normally the issue. It's normally the OMS symptoms, the long-term autoimmunity, and trying to get that under control. So how do we treat it? I'm gonna get some water. So because OMS is really rare and a lot of doctors aren't familiar with the treatment and what you're supposed to do, it's coordinating a lot of different things. The kids are normally sent to one of the specialists. We have Dr. Pranzatelli in Illinois, Dr. Gorman, he is in Boston, and Dr. Mitchell is in LA, California. And so the kids go to those doctors write up the treatment plan, they do the official diagnosis. Sometimes they like do videos of like stacking blocks and stuff to monitor the progress. And then they send that back to a local doctor at the child's hometown. And that's the doctor who kind of oversees and like makes sure that the treatment's going well, looks at side effects, all of that. If they have a relapse, then they go back and see Dr. Pranzatelli, Dr. Mitchell, Dr. Gorman. So this is actually something that we really wanted to emphasize to you guys is it's really difficult to find a local doctor that's willing to work with another doctor. You would think that it wouldn't be so hard, but it's really important to be willing to work with other doctors and communicate and like be willing to be the patient's advocate, because a lot of these kids, like, they know what they have, they know what they need, but then they go home and they can't find somebody to actually give the treatment or help fight with insurance because insurance doesn't want to cover the expensive treatments. So the other thing that some of the parents wanted me to pass along to you is that having like the advocating doctor is really important in situations where kids want to get Make-A-Wish granted, because a lot of these kids actually qualify for Make-A-Wish. All it takes is the doctor to sign off on it, but they have trouble like communicating, getting the doctor to sign off on it. And a lot of these kids have been like in lockdown. I'll talk about some of the treatments. So they go through chemo, and they'll be on lockdown, like in a bubble for 5 years, can't go on vacations or anything. So when they get to the point where they can get a Make-A-Wish or one of those cake icing smile things, it's like the most exciting, special thing for them. So the treatments, IVIG, intravenous immunoglobulins, hard to say. This is the major part of it, and for me, this has been like the biggest part of my recovery. Like when I finally got on IVIG, I was like a completely different person. So what this is it's pooled IgG, some small amount of IgA, and it's given over an infusion over like a number of hours. So, they're not really sure how it works. There's a variety of different theories. The most recent thing Dr. Prince Kelly came out with is that he found that the kids receiving IVIG and Rituxan had decreased levels of APRIL and BAFF B-cell activating factor in their CSF. So he thinks that IVIG is modulating like the cytokine production in the CSF. And this is different than what you'll find in the serum, so it's kind of complicated. I don't fully understand it, but that's how they think it works. The other part is the steroids. So they'll choose between prednisone, dex, and ACTH. The most common are dex and ACTH. Probably ACTH is the primary, most aggressive one that the parents choose. And this is given to the kids by daily injections. That's fun for a little kid. Not really. So the ACTH, sometimes one of the side effects you'll see in a lot of these kids is they get a Cushing-like syndrome, so they'll like be super puffy, they look like they're obese, and people will like say mean things to the parents. That's kind of sad as well. So it works really well, but there could be better treatments out there with more research that have less side effects. The last thing they choose to do is a chemo, so Rituxan or Cytoxan. The most common is Rituxan, that's the most researched in. I think it's FDA approved for OMS actually. So Rituxan works by specifically depleting the B cells so that you can't have those autoimmune antibodies attacking your cerebellum. A lot of parents choose to kind of wait before they do that and see if the IVIG and the steroids will work to get the symptoms under control, but a lot of parents eventually choose to do Rituxan and they swear by it for their kids. One of the common things that you see in OMS is relapses. So it's really common to see in tapering treatment, especially coming off the ACTH as they're decreasing the dose. They'll get to a certain level where all of the symptoms come back. And these are like full-blown relapses where they like go back to what they were like originally, or in some cases even worse. And then they have to go back on IVIG, steroids, another dose of Rituxan. So it can add years to the treatment. But starting treatment early and getting that diagnosis early, it seems like they have more success in tapering. Vaccinations is a huge thing that we're always talking about in the support group. Parents are always like, should we do it or not? Dr. Prince Kelly says, like, absolutely not. Don't have an OMS kid vaccinated, because anything that activates your immune system is going to cause the autoimmune flare-up. And then also with that, live vaccines, if the kids aren't on lockdown and they're going to school, if any kid in their class gets a live vaccine, it could be spread to the child and then they could end up with a relapse. So a lot of parents just choose to keep their kids at home in a bubble. Also, illness is kind of along the same thing as the vaccines and stuff, anything that activates the immune system. I've experienced this. I had like a weird toe infection. I was like, why am I so sick? And then all of a sudden my toe is infected. And I'm like, that's why I'm having a relapse. So it's really weird. It's like you'll be having these increased symptoms and then a week or two later you're like, oh, I have the flu, no wonder why. So sometimes with these situations, they'll require more IVIG or another dose of Rituxan. Sometimes it's just you kind of have worse OMS symptoms for a couple weeks and then you do okay and you don't have to go through more rounds of treatment. So this is the last slide before I share a little more about my story. These are the symptoms in OMS that the parents often are talking about. It's like I said earlier, the Opsoclonus, it looks really unusual and people always focus on that. But sometimes the Opsoclonus will go away or it won't be that prominent, or the myoclonus and ataxia will go away. But the kids will be left with tremors, especially with like fine motor movement in school when they're trying to write or draw and stuff. This is a major issue, rage attacks. These kids, I heard a story about a 2-year-old who threw a TV across the room. Like, and part of this is from the steroids, but part of it is just a behavioral problem with that cerebellum attack. With such little research, there's not a lot of strategies for dealing with these behavioral problems, so that's another area that needs more focus, is dealing with the other symptoms that come along with OMS, not just the Opsoclonus and the myoclonus. Us adults with the adult onset OMS, we really experience a lot of the dizziness and the vomiting and the nausea. That's like some of our biggest complaints. And it seems to go along with the Opsoclonus. I mean, if you can imagine your eyes moving around, you're seeing like the world moving and double and blurry vision. It really makes you feel dizzy and nauseous. These over here are the long-term like developmental like neurobehavioral disorders that are seen, and a lot of kids are given an official diagnosis in their like teens, like as they're starting to go back to school. ADHD is really common. Parents are always describing their kids having like really bad OCD things they like to organize like all the time. So that's really common too. And there's new research talking about the cerebellum's role in these kind of conditions, ADHD, OCD, because again, it's like inhibiting movement and they can't inhibit those things anymore. Oppositional defiant, that's pretty common. Also like separation anxiety. There's teens with that had OMS as kids that just can't like deal with being separated from their parents. This one's also really common in a lot of the teens, bipolar and mood disorders. A lot of them end up speaking like SSRIs and stuff. The learning disabilities, those are more like reading and writing issues in school. A lot of them will get like IEPs and stuff in school to get help with that. And again, that really, they need the support of their doctor, the local doctor, to get those assistances that they need. This one is kind of interesting. There's just a couple cases of it, but there's a couple kids I know of that are teens now, and they can't regulate their heart rate and their blood pressure anymore, and they think that that's partially due to the autoimmune attack on their brain, but also part of the long-term steroid use. So those are kind of some of the long-term issues, and there needs to be more research on those things as well. So that's why we do our teddy bear drive, so that we can really support more research and give out grants for research on these things.